It is my pleasure to introduce you to Dr. Clyde Marquez, who graduated from the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences in 2022. He is currently a first-year resident at the University of Utah Health and will continue his training in their PGY2 critical care program. His professional accomplishments include a publication in the Journal of American Pharmacists Association, national research presentations at ASHP Midyear, and Vizient Pharmacy Network meetings, and is a member of Phi Lambda Sigma and the Rho Chi Society. His areas of interest include critical care, infectious diseases, and cardiology. And while on rotation with the cardiovascular medicine unit pharmacists at the University of Utah Health, many patients started lifelong therapy with amiodarone to manage their arrhythmias. And this sparked his interest to further delve into amiodarone toxicities and monitoring to better inform healthcare providers and his patients. And with that, Clyde, I will turn it over to you.
Thank you very much for the introduction, Kimmy. So again, my name's Clyde, and today we'll be talking about amiodarone-induced toxicities. We'll go over each of the mechanisms, sort of the timing of these toxicities, and some of the monitoring that we can do for our patients. For disclosures, no financial conflicts of interest to disclose on my behalf or my CE mentor, Irene. And in terms of off-label uses of medications, just a few off-label uses for amiodarone that we'll talk about. So at the conclusion of the CE, our pharmacists should be able to differentiate between the pathophysiology of each amiodarone-induced toxicity, describe the clinical presentation and treatment of amiodarone-induced toxicities, recognize the incidence of different toxicities and the general timeline when each may occur, and formulate baseline testing and monitoring strategies for those different toxicities. Our technicians should be able to successfully identify appropriate indications for amiodarone and distinguish between look-alike, sound-alike medications, and recognize that amiodarone is on the ISMP list for high-risk medications, and should be able to examine and recall major drug-drug interactions between amiodarone and other medications. We'll start by going into some background with amiodarone and some of the PK and drug interaction information. So to start, some history of amiodarone. It was derived from a plant found in the Mediterranean countries. It was synthesized back in the 1960s in Belgium as an anti-anginal agent initially. Its antiarrhythmic properties were described in the 1970s by some pretty famous researchers, Dr. Sin, von Williams, and Dr. Rosenbaum. And then finally in 1985, amiodarone was FDA approved for ventricular and supraventricular arrhythmias. In terms of its place in clinical practice, oral administration is primarily used to prevent recurrent atrial fibrillation or atrial flutter. We use it for rate control of atrial fibrillation or atrial flutter in patients with rapid ventricular rate or supraventricular tachycardias. We can also use it for pharmacological cardioversion of atrial flutter or AFib, and we also use it in patients with Wolff-Parkinson-White syndrome. IV administration of amiodarone is often used in shock refractory ventricular fibrillation or pulsus ventricular tachycardia, and also for rate control in patients with atrial fibrillation with rapid ventricular rate or supraventricular tachycardias that need urgent control, and also IV administration for treatment of electrical storm or those incessant ventricular tachycardias. For pharmacokinetics of amiodarone, for its absorption, bioavailability is about 50%. Oral time to peak for amiodarone is 3 to 7 hours, although it's important to note that the time to peak doesn't necessarily equate to time to efficacy, and that can vary. For distribution, it's highly protein bound and has a very large volume of distribution. Amiodarone is extremely lipophilic, and that's kind of the backbone to all these toxicities that we'll talk about. For metabolism, primarily hepatic through CYP3A4 and TC9, and it's metabolized to an active metabolite, N-desethyl amiodarone. For elimination, the average half-life is about 58 days, but it's highly variable across patients, anywhere from 15 to 142 days, mainly excreted in the feces, and amiodarone is not dialyzed. Important to note that even in older adults who have lower clearance, they can also have prolonged half-lives, maybe beyond 58 days, and especially in cirrhotics too, they can also have longer half-lives. So things to consider when you're starting amiodarone in those patients. In terms of mechanism of action, it targets a lot of different ion channels and a couple different receptors. So amiodarone blocks potassium, sodium, and calcium channels. And the overall goal of targeting those channels is to decrease conduction through the myocardium and help reduce some of the excitability in the heart. And amiodarone also has beta blocking effects and alpha receptor blocking effects. The beta blocking effects will help decrease heart rate and kind of protect the heart from pro-dysrhythmic effects of catecholamines. And some off-target effects like blocking alpha receptors can cause some peripheral vasodilation. In terms of significant drug-drug interactions, mechanisms are primarily through inhibition of CYP3A4, 2C9, and 2D6. And amiodarone is also a strong inhibitor of P-glycoprotein transporters. So the three medications I have listed here, I have them highlighted because these are narrow therapeutic medications. So it's important to monitor patients closely when they're on both these medications and amiodarone. So as you might recognize, warfarin, these warfarin concentrations can increase due to inhibition of 2C9. Digoxin concentrations can also increase by blocking those PGP efflux proteins, and colchicine concentrations can also increase by both blocking PGP and inhibiting 3A4. Some of the other effects that amiodarone can have is, we'll talk a little bit about, is it can prolong the QTC. So important to also monitor for other QTC prolonging drugs, but we'll discuss that in more detail in a few slides. In terms of some ISMP information on amiodarone, so it is on the list of confused drug names. So the notable ones that they point out is amantadine compared to amiodarone, kind of easy to mix those up by how they're spelled. It's on the list of high alert medications in acute care settings. If amiodarone is given in error and the patient doesn't have an indication, it can cause arrhythmias, bradycardia, and hypotension. The hypotension is mostly associated with those rapid IV boluses, specifically in formulations that contain polysorbate 80. And for amiodarone did appear on a medication safety alert back in October of 2019, where at one institution, there were 3 separate instances where amiodarone was confused with IV nicardipine. So if you've seen the cartons for both of those, the coloring is similar, the carton shape is similar, the IV bags are similar, so something to watch out for too when you're grabbing that medication to get it ready to be dispensed. Some personal safety and handling information for amiodarone. So it's not classified as a hazardous drug by the National Institute for Occupational Safety and Health, or NIOSH, but it is sort of recognized as a category 2 medication in terms of safety for carcinogenicity and reproductive toxicity. Category 2 is just meaning it's a suspected cause. So because of that, if you are handling the actual drug using eye contact protection with safety glasses or goggles, and skin contact protection with impervious gloves or protective clothing, things with nitrile. So this will lead us into our first question. So our first question is, in which of the following clinical scenarios would you not use amiodarone? A, atrial fibrillation, B, ventricular tachycardias, C, major depressive disorder, and D, pharmacologic cardioversion of atrial flutter. I'll just give it a few seconds for people to get some responses in. Okay, so let's take a look at our correct answer. So you would not use amiodarone for major depressive disorder. Please don't. For atrial fibrillation, that is not the correct answer because it is a use for amiodarone. It's off-label use technically. Ventricular tachycardias is not correct because it's actually a labeled indication for amiodarone. And similarly, pharmacologic cardioversion of atrial flutter, It's an off-label use, but it is an appropriate clinical scenario where we would use amiodarone. So we'll take a look at our next question. We'll have a second knowledge check. So for this question, the question is based on the ISMP list of confused drug names, which of the following is confused with amiodarone? A, amitriptyline, B, amantadine, C, amoxicillin, or D, anastrozole? These could all be mixed up. Kind of the same. Okay, got some more responses this time. So let's take a look at the answers. So great work. Amantadine is on the ISMP list. Amitriptyline, amoxicillin, and anastrozole are actually not listed on the list of confusing drug names. So amantadine is one to really think about. Great. Thank you for your responses. So we'll go into our first toxicity, which is our most common toxicity with amiodarone. So thyroid toxicity. There are a few different manifestations of thyroid toxicity. One is hypothyroidism induced by amiodarone. The incidence is up to 26%, so it's one of our more common toxicities. Patients are going to present with symptoms pretty typical of hypothyroidism, so cool and dry skin, fatigue, constipation, some weight gain. They might have a slow heart rate, although that might be compounded by the amiodarone, and some fatigue. Some of the risk factors really depend on the patient. And so because of that, we have a pretty variable onset, so anywhere between 2 weeks to 39 months. I will note that patients with underlying Hashimoto's thyroiditis or patients who were tested and are positive for anti-thyroid antibodies are more likely to develop persistent hypothyroidism after starting amiodarone. In terms of thyroid function labs and running those tests, it's going to be pretty standard for hypothyroidism. Patient's going to have an elevated TSH and a normal or low T4. Risk factors are additional exogenous intake of iodine through diet, again, presence of those thyroid autoantibodies, and being female, potentially because Hashimoto's is more common in females. Another type of toxicity is amiodarone-induced hyperthyroidism, or AIT for short. The incidence depends on the geographical region and the prevalence of iodine deficiency in those regions. Patients will also present pretty typical of hyperthyroidism, so they'll be restless, have some weight loss, tachycardia, some heat intolerance, and they might even present with some supraventricular arrhythmias. The time to onset of AIT is typically 2 years, but in the literature, it does appear kind of unpredictable. And we'll talk about this in more detail, but AIT can present as 2 different types, and they're managed differently, type 1 and type 2. Our thyroid function labs are going to reveal elevated T3 and a T4 and a low TSH, so something you might expect for hyperthyroidism. Risk factors: low dietary iodine intake, pre-existing thyroid disease in males. Differentiating a little more between the AIT types. So for type 1, this is more common in patients who happen to have underlying thyroid disease. So on ultrasound in these patients, you might see diffuse or nodular goiter. The pathogenesis I'll mention on the next slide, but it is iodine induced. These patients tend to not spontaneously remit out of hyperthyroidism, and also tend to not have any sort of hypothyroidism after treating their hyperthyroidism. And they often do require treatment for hyperthyroidism after potentially stopping amiodarone. The prevalence is more common for type 1 in iodine deficient regions outside of the US, and that's specific countries like Western Africa, India, South Asia, regions that have issues with iodine deficiency. That's where we see more type 1. For type 2, these patients tend to have normal thyroids. Ultrasound shows a normal gland. Pathogenesis is more destructive, direct cytotoxicity from amiodarone. These patients can spontaneously remit and may have some hypothyroidism after treating. And then it's more common in the United States for patients to have type 2 AIT caused by amiodarone. So the mechanisms for these toxicities, so for hyperthyroidism, it's pretty interesting, a few different proposed mechanisms. So thought to occur from escaping the Wolff-Chaikoff effect. And if you haven't heard what that is, it's basically this process that the body undergoes to prevent additional iodine uptake into the thyroid. And the thyroid kind of detects that and stops producing thyroid hormones. And so after a prolonged exposure to amiodarone, there's too much iodine present. And so the body is unable to keep up that Wolff-Chaikoff effect. And then the body reverts back to producing normal amounts of thyroid hormone despite all this iodine being available. Amiodarone can also potentially inhibit our 5' monodeiodinases. So these are enzymes that produce some of our thyroid hormones, and then also preventing T4 and T3 uptake by different cell lines throughout the body. For hyperthyroidism, type 1, kind of like I mentioned, the mechanism is having an abnormal thyroid gland at baseline. And then in the presence of amiodarone, patients have increased synthesis of thyroid hormones because of those increased iodine levels. And for type 2, the one that's more common in the United States, it's mainly caused from direct cytotoxicity of amiodarone to the thyroid because it is so lipophilic. In terms of managing hypothyroidism, so it's pretty straightforward. If you have a patient on amiodarone and they develop hypothyroidism, you're often just going to replete with T4 and try to normalize their thyroid function. One thing to note is that these patients may require higher doses of T4 than you would expect because they're on amiodarone. That's required to restore some normal TSH levels. And in most cases, it's completely fine to continue amiodarone in these patients. There's no need to discontinue it. You can simply treat through their hypothyroidism and leave them on their therapy. For monitoring, ideally you want to get a baseline TSH, T3, and T4 in your patients to monitor for changes and have a baseline established. And when you're initiating treatment for hypothyroidism, checking their thyroid labs in 4 to 8 weeks, titrating as needed, and once they're stable, you can check labs every 6 to 12 months. Type 1 and type 2 are managed a little differently. For type 1, these patients are going to be managed like a kind of a typical hyperthyroid patient. You'll use things like methimazole. Patients might require up to 40 to 60 milligrams per day, or you can use some equivalent propylthiouracil dose. So the thiamides are sort of the mainstay of treatment for type 1 AIT. And in these cases, it is okay to continue amiodarone, but that sort of begs the question, should you continue amiodarone? And some important things to think about: if your patient's being treated for a life-threatening ventricular arrhythmia and amiodarone's what's keeping them in a normal rhythm, then absolutely you would continue amiodarone. It's not worth stopping it, and you simply treat through their hyperthyroidism. And another thing to note is that even if you do stop amiodarone in these patients, you're not really going to see a benefit up front because of that long half-life that amiodarone has. So you're going to be treating hyperthyroid symptoms for quite some time, even after stopping amiodarone. So just sort of thinking about those things if you're considering stopping amiodarone. For monitoring, you'll just repeat thyroid function tests every 3 to 6 months until the patient's euthyroid. And then something to just acknowledge is that if you're continuing amiodarone, patients will likely need prolonged thionamide therapy. For type 2 management, this is going to be a little different. So not how we would otherwise treat a hyperthyroid patient. Our 2018 ETA guidelines for the management of amiodarone-associated thyroid dysfunction recommend starting prednisone in these patients to normalize their thyroid levels. So we could start prednisone at 0.5 milligrams per kilogram per day. And then once their thyroid levels normalize, you can begin reducing their dose by 0.1 milligrams per kilogram every 1 to 2 weeks. And similar rationale with AIT type 1, you can likely continue amiodarone and treat through the hyperthyroidism or assess if there's a possibility to stop it, but you'll likely be able to continue it. And then for monitoring, again, just continuing the prednisone until those thyroid hormones normalize and then beginning a taper once they do. And even though most patients might need to be kept on amiodarone, they still respond after starting prednisone. So something to keep in mind. Here is another knowledge check question. So for this one, you might already be answering. Where would you expect AIT type 2 to be more prevalent? A, Western Africa, B, India, C, South Asia, or D, North America? Not as many responses for this one. It's okay. Okay. So great job, North America. So again, AIT type 1 is more prevalent in geographical regions that have more iodine deficiency. And that's not really a thing in the United States. So that's why we see more of type 2 in the US. Okay, so we have another question. So now we have a case here. So I'll read through the case here first, and then I'll go to the poll everywhere. But we have an 80-kilogram, 65-year-old male presents to their PCP clinic with symptoms of restlessness, weight loss, and tachycardia. He's 1 year into amiodarone treatment for suppression of recurrent ventricular tachycardia. His thyroid function test showed elevated T3 and T4 with a low TSH. A provider consults you, the pharmacist, asking for a recommendation. Which of the following interventions would be reasonable to recommend along with a referral to an endocrinologist? Someone was really fast. That's cool. I might give it a few more seconds in case you have to read the case. Okay, let's take a look at the responses. So, okay, kind of a split between, no, you can't change your answers anymore. Kind of a split between B and D. So let's take a look at these answers. So A is incorrect. Why is A incorrect? So for this case, it was important for you to identify that this is likely type 2 amiodarone-induced hyperthyroidism, since we are here in the US. So type 1 is much less likely, so we wouldn't recommend starting methimazole. And for B, which is our correct answer, if you correctly identify that sounds more like a type 2 AIT picture, then we would recommend prednisone. I just take their weight, cut it in half, and that's their dose, so 40 milligrams daily. For question or answer C, discontinue amiodarone, in this case is incorrect because like we talked about, hyperthyroidism is something that we can treat through in the presence of amiodarone. And another thing that was important to note was that this patient was being treated for a recurrent ventricular tachycardia. So they have a very good reason to be on amiodarone. And if we were to take them off amiodarone and leave that issue untreated, we could potentially risk throwing them into a life-threatening arrhythmia. And then for D, starting levothyroxine, so appropriately identifying in their side effect profile, this sounds more like hyperthyroidism, and then in addition to their elevated T3 and T4, that should include you into that this was a hyperthyroidism picture, and D is appropriate for hypothyroidism. Okay. So next, we'll start talking about pulmonary toxicity, which is our next most common toxicity. So the way this manifests is with pretty non-specific symptoms. So patients will have a non-productive cough, some shortness of breath, pleuritic pain, fever, some weight loss. If you perform a pulmonary function test in these patients, they'll have more of a restrictive or mixed restrictive obstructive airway disease and some reduced diffusion capacity. Pulmonary toxicity with amiodarone typically manifests as an interstitial pneumonitis, but other pulmonary complications are possible. Some of the things in the literature and in case reports are organizing pneumonia, eosinophilic pneumonias, and in very rare cases, acute respiratory distress syndrome. Toxicities can develop in as little as 2 days in patients where we start amiodarone, but again, up to several months after starting therapy. So kind of variable in terms of onset. And then for chest x-ray findings, these patients will usually have newer localized diffuse opacities. Incidence is very low. It's pretty rare, about 5%. Literature ranges between 2 and 70%. And some of our known risk factors are the daily dose of amiodarone and their cumulative dose, so over 100 grams in their lifetime. Being over 60 years old, longer durations of therapy, of course, are going to increase your risk. And one other thing that's interesting to think about is pre-existing lung disease being a risk factor. So if you are deciding to start amiodarone in a patient who does have a history of pre-existing lung disease, it's going to require a risk-benefit discussion with the provider that you're working with and the patient themselves. It's unclear whether there is a true contraindication in patients with pre-existing lung disease. A lot of the major trials that included amiodarone were not clear whether or not they included or excluded patients that had pre-existing lung disease. However, there was a study by Oshalansky and colleagues that looked at the incidence of pulmonary toxicity in patients that were enrolled in the AFFIRM trial that was published in 2002. It compared rate control and rhythm control in patients with AFib. And they saw that using amiodarone in the presence of pre-existing pulmonary disease did not necessarily increase pulmonary death or all-cause mortality. So it may not necessarily be a contraindication. So just something to sort of discuss with the patient, that the risk is there, that may worsen, but it's not a definite risk. In terms of the mechanism of pulmonary toxicity, so it's thought to occur through two different ways: direct cytotoxicity from amiodarone and indirect immune reactions that are occurring in the lungs. So amiodarone lipid complexes tend to accumulate in lung tissues, and then it interferes with metabolic pathways, and you end up having cell death. One of the characteristic pathological findings is you'll see lipid-rich macrophages in alveolar spaces. And one of the other proposed mechanisms is amiodarone can generate radical oxygen species, which is cytotoxic. And then you'll also see lymphocytic infiltration and recruitment of cytotoxic T cells into the lung space, which is part of that indirect immune reaction. In terms of managing pulmonary toxicity, so in these kind of patients, if you're positive that they're having pulmonary toxicity from amiodarone, ideally you would discontinue amiodarone if possible. But if you are able to stop amiodarone and use an alternative agent, it's important to acknowledge that resolution of those pulmonary symptoms is going to be slow, because it's going to take time for the amiodarone to clear, and some of that damage is lasting damage to the lungs. If a patient is on amiodarone and it's being used again to prevent a life-threatening arrhythmia, it might be difficult to convince a cardiologist, for example, to stop that medication. So again, important to assess why the patient's on amiodarone, because if it's for other indications like atrial fibrillation, you can potentially consider other agents. There's few literature out that suggests potentially 40 to 60 milligrams of prednisone daily, followed by a gradual taper, could potentially help improve symptoms in these patients. Those who have shortness of breath at rest or requiring oxygen. So one potential intervention that you could consider recommending. In terms of monitoring for pulmonary toxicity, so checking a baseline chest x-ray, and then yearly to assess for any abnormal changes, checking baseline pulmonary function tests, and then as needed. And then one important thing to note, there have been studies to see if amiodarone blood concentrations can predict pulmonary toxicity, but that hasn't been shown to be the case. So amiodarone blood concentrations are not useful in predicting pulmonary toxicity. Let's move on to one other question. So another knowledge check. So for this question, a primary care provider calls your clinic about a patient who was recently started on amiodarone after a hospital admission. Which of the following monitoring strategies for pulmonary toxicity is appropriate to recommend? And that's A, baseline potassium and magnesium, and then repeating those as needed. B, checking baseline serum TSH, T3, and T4 levels. C, a baseline annual chest x-ray and PFTs. Or D, checking amiodarone concentrations every 3 months. Okay, I think we got some good responses in. So let's take a look. And yeah, majority selected C. So excellent. That is the correct answer. This is supported by primary literature, and it's an appropriate way to assess for pulmonary toxicity. A is not correct. Assessing potassium and magnesium is not helpful, and we'll see in a few slides here, this is a little more helpful for monitoring cardiotoxicity. For B, these are thyroid labs, so your brain should think thyroid toxicity. So that is an incorrect thing to recommend because that monitors for thyroid toxicity. And then D is also incorrect because, as we just mentioned, amiodarone levels have no clinical utility or usefulness in predicting pulmonary toxicity. But great, thank you for your responses. Next, we'll talk about potential cardiac toxicity with amiodarone. So overall, cardiac toxicity is pretty rare with amiodarone. If it does happen, it's really just potentiation of sort of those expected pharmacological properties that we would expect, or those electrophysiologic effects from amiodarone. Some of the notable things that might manifest are bradycardia. So incidence is pretty rare for bradycardia, and there's different things that can cause bradycardia, but something that could occur after several years of treatment with amiodarone. At presentation, the patient might have presyncope. They could be presyncopal, had syncope, lightheadedness, or fatigue. And some of the risk factors for bradycardia or even atrioventricular blockade would be concomitant use of negative inotropic medications, so diltiazem and beta blockers. And another notable risk factor is patients 65 or older who have a history of myocardial infarction, and the thought there being that these patients might have scar tissue in their heart and might be susceptible to conduction abnormalities because of that. Amiodarone can also exacerbate arrhythmias that are already present in the patient. Incidence is also pretty low, 2 to 5%. Starting amiodarone will introduce a theoretical potential for new arrhythmias. So examples are noted here, but these are pretty serious. These mostly occur in an unpredictable fashion, so hard to really estimate or predict whether it's going to occur in your patient. But some of the risk factors that we do know about is your patient is hypokalemic or hypomagnesemic, or if the patient is on more than one medication that can prolong the QT interval. And that's specifically for the rare risk of torsades being caused by amiodarone. For the mechanism of cardiotoxicity, the bradycardia that we can see and the AV blockade, that's really due to amiodarone reducing AV nodal conduction, which is primarily driven by those beta receptor blocking effects and the calcium channel inhibition that we talked about earlier in the presentation. Another thing to note is torsades is a possibility. It's extremely rare, but it's thought to occur from amiodarone because of its ability to block potassium channels, which will prolong the effective refractory period, which prolongs the QT interval and then leaves your patient susceptible to developing torsades. However, the reason we don't really see torsades in these patients, some of the proposed mechanisms are that risk is reduced by an increase in the action potential duration by beta blockade and decreasing early after depolarizations by calcium channel blockade. And those are just some of the components that drive the risk of torsades. In terms of managing cardiac toxicity, for treating a patient that has symptomatic bradycardia or high-grade AV block, you can stop amiodarone and you can consider reducing the dose of amiodarone, or you can consider stopping or reducing the dose of any contributing medications. If the patient is in torsades, then you would just treat the torsades. So we would give them IV magnesium and perhaps a positive chronotrope and antiarrhythmics as needed to get them out of that arrhythmia. And to help prevent the risk of torsades, we want to maintain their potassium and magnesium levels in sufficient amounts. So potassium over 4, magnesium over 2 is what you'll hear to help kind of reduce the risk of torsades. And then for monitoring for some of these arrhythmias with amiodarone, just making sure you check their baseline potassium and magnesium and replete as needed. And you can also consider checking a baseline electrocardiogram and repeating it when you are starting any additional QT prolonging agents to sort of monitor that QT interval. And then, of course, monitoring their heart rate throughout therapy and monitoring for bradycardia and symptoms of bradycardia. Okay, next we have another question. So let's go back here. So which of the following medications does not have a major drug-drug interaction with amiodarone? A, acetaminophen, B, digoxin, C, colchicine, and D, warfarin. Okay, oh, coming in. Okay, let's take a look at some of your answers. So great work. Acetaminophen is not a major drug-drug interaction with amiodarone. Digoxin, like we talked about, narrow therapeutic index drug, efflux by PGP, so major interaction there. Colchicine, also effluxed by PGP and metabolized by CYP3A4, so major interaction there. And then also with warfarin, another narrow therapeutic index drug, metabolized by CYP2C9. Amiodarone inhibits that, so that is another major interaction. Okay. Next, we'll talk a little bit about hepatic toxicity with amiodarone. So transient elevations in the patient's liver enzymes is possible, and it can occur in about 15 to 50% of patients upon starting amiodarone. Only about 1 to 3% of those patients actually develop some sort of amiodarone-associated liver injury, and then they manifest with typical symptoms of liver injury. Acute toxicity can manifest within a day, but it can take longer periods of time to really develop in terms of those chronic toxicities. The elevations are usually mild to moderate in their liver enzymes and can present in either a hepatocellular injury pattern where they have a severely elevated ALT, or a more cholestatic pattern where they have a minor ALT increase and a pretty significant alkaline phosphatase increase. Risk factors for chronic toxicity are cumulative doses, and acute toxicity are going to be, again, higher doses, IV administration in older patients. And so this makes us ask, what about starting amiodarone in patients with cirrhosis? So unfortunately, in the literature, there are no specific recommendations available, but you can consider decreasing or stopping amiodarone if the patient's LFTs are 3 times greater than the upper limit of normal, just because of the risk of adverse effects with amiodarone. Other things to acknowledge in cirrhotics, like we mentioned, half-life is prolonged. And one thing you can consider doing in cirrhotics is trying to use other antiarrhythmics before considering using amiodarone. And if you do have to use amiodarone in cirrhosis, starting at the lowest dose possible and titrating to the lowest effective dose to control the arrhythmia. For the mechanism of hepatotoxicity, similar to pulmonary toxicity, it directly damages the liver. It damages those phospholipid biolators and leads to accumulation of lipids in the liver, which can cause apoptosis of hepatocytes, which can lead to fibrosis and development of what are called Mallory bodies, which are hyaline that accumulates inside hepatocytes. And then polysorbate 80, which is found in our IV formulations, can also destabilize cell membranes and predispose patients to steatosis. In terms of management, for acute or chronic LFT elevations, basically you can just monitor for symptoms of hepatitis before recommending any kind of intervention. For patients that do have symptomatic hepatitis, or their LFTs are persistently elevated 2 to 5 times the upper limit of normal, in those cases, for their safety, you would want to consider discontinuing amiodarone. And then for monitoring, just checking a baseline liver function test, and then assessing them around every 6 months is kind of what the literature suggests to monitor for any sort of changes. If the patient does develop hepatic or amiodarone-associated liver injury and you have to continue amiodarone, one thing that you can do to decide whether you need to actually stop amiodarone in that case is performing a liver biopsy. And that can kind of dictate whether you can continue amiodarone or you absolutely have to stop. Next, we'll talk about potential ocular toxicities with amiodarone. One of the most common manifestations are what are called corneal microdeposits, and you can kind of see a picture here on the right. Those, what looks like dust on top of the eye, is those are actually microdeposits of amiodarone. The incidence of symptomatic deposits is very rare, so only about 1.5%. So although these deposits are pretty common if you examine patients that have been on amiodarone for a while, more often than not they're not symptomatic. If they are symptomatic, they'll report blue-green rings or halos around lights, and you would be able to see corneal opacities on both eyes from an exam. And very rarely does this actually lead to vision loss. In terms of when this forms, usually within 1 to 30 months of starting therapy, and this tends to resolve after stopping amiodarone. Higher doses are associated with greater deposition of microdeposits, which is pretty intuitive. And then risk factor, also intuitive, extended durations of therapy are going to increase risk in patients. Optic neuropathy is another possibility. Also, incidence is very low, 0.3 to 2% is cited in the literature. Patients present with mild reversible vision loss or potentially permanent blindness. Most cases take a while to present, usually 12 months after therapy. And there's limited data on risk factors. So it's generally thought to occur in a dose-dependent manner with longer durations of therapy with amiodarone. But the issue is that there are other factors that can increase a patient's risk for optic neuropathy. So kind of hard to pinpoint what are some specific risk factors. And there's also no screening protocol or like a defined risk stratification strategy for patients that do develop what's called amiodarone-associated optic neuropathy. In terms of the mechanism for ocular toxicities, amiodarone forms, again, forming lipid complexes like we see in the liver and in the lungs, where they accumulate in the corneal epithelium and they actually start to sort of become noticeable on exam. And then for optic neuropathy, kind of interesting, the patient will develop what are called lamellar bodies in their large optic nerve axons. And these lamellar bodies lead to decreased exoplasmic flow, and they actually cause the optic disc to swell. And the optic disc swelling is what leads to blurred vision, double vision, and potentially vision loss. In terms of managing ocular toxicity, most cases of corneal microdeposits don't require an intervention. Like I said, symptomatic manifestations are very rare. If they do occur, there are some potential laser treatments that the patient could go through if they absolutely needed to remove those microdeposits. If their vision is impaired, you can consider discontinuing or dose reducing amiodarone using similar rationale like we discussed for previous toxicities. Like I mentioned, laser treatment for significant corneal deposits. And then if you do suspect that the patient's optic neuropathy is being caused by amiodarone, again, before stopping it, important to discuss with a cardiologist or whatever physician is managing their amiodarone to make sure that is the most appropriate choice for the patient. Then for monitoring, just a baseline eye exam and then yearly, like typical, is sufficient to monitor for this toxicity. We have another question here. We'll go to Pull Everywhere. So the question is, what is a mechanism of ocular toxicity with amiodarone? And then this is a select all that apply. So for ocular toxicity, is it because of an inability to escape the Wolff-Chaikoff effect, which can lead to permanent blindness, for A? For B, lamellar bodies accumulate in optic nerves, leading to optic nerve swelling. C, amiodarone lipid complexes accumulate inside the corneal epithelium. Or D, amiodarone blocks potassium channels in the eye, which leads to optic nerve damage. I'll give you a couple seconds to answer. Okay, great. Let's take a look. So, great work. B and C were the majority. So both of those are, someone changed their answer. B and C are correct. So B is the mechanism for optic neuropathy, like we talked about, optic nerve swelling. And C is the mechanism for corneal microdeposits, like we talked about, amiodarone lipid complexes precipitating in the eye. A, inability to escape the Wolff-Chaikoff effect, leading to permanent blindness. That's not a thing. Not escaping the Wolff-Chaikoff effect is what leads to amiodarone-induced hypothyroidism, like we talked about. And then amiodarone blocking potassium channels in the eye leading to optic nerve damage, or D. That's not a mechanism for ocular toxicity. Blocking potassium channels can actually potentially lead to bradycardia or AV block, kind of like we talked about. But great, thank you for your responses. And that was our last question. So as we kind of get to the end of this presentation, we'll just start talking about some other miscellaneous toxicities. Dermatologic toxicities are possible. Incidence is about 2% with higher doses. When higher doses were used in the past, which is not something we really see anymore since our doses now are lower compared to when amiodarone was first starting to be used. So dermatologic manifestations are very rare. Patients can develop photosensitivity with or without a rash. What you may have heard about is blue man syndrome or hyperpigmentation being caused by amiodarone, and the mechanism for this is there's an accumulation of what's called lipofuscin in the lysosomes of dermal cells, and lipofuscin has a bluish brownish pigment itself. The extent of pigmentation appears to be dose related, with pigmentation improving at dose reductions of amiodarone. And then for either of these scenarios or dermatologic manifestations, avoiding excessive sun exposure and using sunscreen to protect your skin are good ways to help prevent that. And again, onset is typically with longer durations of therapy over a year. Neurologic toxicity is also talked about in the literature, presents pretty broadly: tremor, gait ataxia, cognitive impairment. Very rare cases, it's been thought to cause Parkinson's disease or myopathies. Incidence is very rare, 1.6%. Main risk factor only appears to be long durations of therapy and lower risk with lower doses. But one thing to note is that if the patient does start presenting any of these neurologic symptoms, it's best to only consider amiodarone as a possible culprit after you've ruled out probably several other diagnoses before pinning it on amiodarone and just stopping amiodarone, but still something that's possible with amiodarone. Safety in pregnancy and breastfeeding. So this is worth mentioning. So amiodarone can increase the risk of neonatal hypo and hyperthyroidism, bradycardia in the neonate, neurodevelopmental abnormalities, and a few other things. So in pregnant women, it's not a first-line option for chronic management of any arrhythmia such as atrial fibrillation. And if we are going to use amiodarone in a pregnant patient, we would want to reserve it for refractory arrhythmias. Concentrations in the breast milk vary, anywhere from 3.5 to 45% is reported, but the package insert for amiodarone recommends avoiding breastfeeding. But depending on what literature you cite, some support actually going ahead and using amiodarone and simply monitoring the infant's thyroid and performing cardiac monitoring in the infant to monitor for safety. But overall, amiodarone is not considered teratogenic. That's another thing to point out. And then lastly, our last toxicity, acute overdose toxicity. So ingestions are possible, and these ingestions will often present with exacerbated electrophysiological effects, more of that cardiac toxicity, and the patient can develop subsequent cardiovascular collapse. Presentation is going to be characteristic of the effects of amiodarone, so severe bradycardia, high degree AV blockade, prolonged QT interval. They could be in a malignant tachycardia. They'll be hypotensive and potentially could present or go into cardiac arrest. So for managing, of course, just your typical immediate supportive measures required, securing the patient's airway and assessing them from that standpoint. We can consider starting fluids with or without vasopressors to manage any hypotension, enacting, your ACLS, acute cardiac life support measures as needed if the patient does arrest, and then you can consider consulting poison control for further management and stabilization of the patient. But if a patient like this presents to the ED with a suspected amiodarone ingestion, then you would absolutely want to aggressively replete any potassium or magnesium to prevent torsades, and then starting continuous cardiac monitoring in that patient. So to conclude the presentation, just a few points to note. So what about dronedarone? You probably were wondering why we didn't talk about this yet. So dronedarone is unique, a unique cousin to amiodarone in that it lacks iodine. And so it's essentially void of the risk of thyroid toxicity. So if your patient does develop thyroid toxicity on amiodarone, switching to dronedarone may be a reasonable switch to spare them that toxicity risk. However, if your patient did develop lung toxicity or liver toxicity thought to be due to amiodarone, it is contraindicated in those patients because dronedarone itself carries its own risk of lung toxicity and liver toxicity. So this would not be an option in those patients. And then one other thing to note, a contraindication for dronedarone is it's contraindicated in patients with New York Heart Association class 3 or 4 symptoms for heart failure or recent less than 4-week hospitalization for decompensated heart failure. One other thing to note is you can still think about starting dronedarone in patients that have a history of pulmonary toxicity thought to be associated to amiodarone. But again, in those cases, it's best to have more of a risk-benefit discussion with the patient, especially, and then with the team as well. But it's still good to note that a history of pulmonary toxicity from amiodarone is not a contraindication to using dronedarone. And finally, some key takeaways for this presentation. So presently, amiodarone toxicity is very rare, as maintenance doses that we use today are much lower than maintenance doses that we used to use in the 1980s. Back then, patients would get around 600 milligrams a day of amiodarone. Most of the mechanisms that we talked about are caused by cellular damage from amiodarone lipid complexes that accumulate in all different cell types throughout our body because we have lipids everywhere in our body. And baseline and routine imaging and laboratory tests should be obtained in all of your patients who are starting amiodarone to monitor for these toxicities. And then in any patient, it's always important to educate them on the risks of amiodarone therapy and the symptoms associated with these toxicities. So with that, that concludes this presentation. Here are all the references. You can read them really fast. And then here is the CE code.
Thank you so much for that presentation. So the CE code today is CMZ522. If there are any questions from any of our participants today, please feel free to put them in the chat or unmute yourself. Okay, well, I don't see anything. Thank you so much for your presentation, and it was a great overview. I really appreciated it. Definitely, we see this sometimes and always wonder, is it amiodarone induced or not? So thank you so much for this presentation. Everyone have a great afternoon. If you have any questions, remember, please register for the event if you want CE credit by April 11th. And then all evaluations are due by April 18th. Again, our handouts are available on the website, at USHP's website. And if you have any questions, I will be available for another few minutes on the Zoom call. Thank you. Thank you.